Hi, I'm Dr. Laura Roberts, Editor-in-Chief for the Books Portfolio of the American Psychiatric Association, and welcome to the APA Books Podcast. Well, welcome everyone. I'm so pleased to talk with you today with Psychiatry Unbound. This is a podcast of the American Psychiatric Association's publishing portfolio. And today we're going to be speaking with just one of the most special people I've known in my life and in my career, Petros Levounis. Petros is a graduate of Stanford University, and since I'm broadcasting from the Stanford University campus, I would give a little emphasis and shout out there. And Petros serves as a professor and the chairman of the Department of Psychiatry at Rutgers, New Jersey Medical School. He's also the chief of the psychiatry service at University Hospital in Newark, New Jersey. Petros is a polymath. He's good at pretty much everything, I think. Board certified in general psychiatry and addiction psychiatry. He's also certified in addiction medicine. He has written many, many books. We'll talk about that in just a minute. But this morning, he's generously agreed to talk with us about his upcoming book, The Pocket Guide for LGBTQ Mental Health. Petros, welcome to the APA Books Podcast.
Hi, Laura. Thank you so much for having me on your show, and thanks for the kind words, too.
Yeah.
You're one of the very most special people I know, too, so thank you.
We'll have a love fest with our podcast.
Yes.
So, Petros, tell me about this book, this pocket guide, and where the idea came from, and what was the inspiration behind this work?
It's the product of two different ideas. One is we've done some LGBTQ work before, and we did the LGBTQ Casebook, which is primarily addressed to the U.S. psychiatrist. And then we did a pocket guide to addiction assessment and treatment, which was a much smaller volume and really addressed not only to the U.S. psychiatrists, but to an international audience. We worked hard to put our ideas as to be so that they are applicable to a wider audience. So after the success of the pocket guide to addiction assessment and treatment, we said to ourselves, why don't we do a similar thing for the LGBTQ mental health work that we've done. And that's where the pocket guide idea came about.
Yeah, and so the pocket guide, a project that you and Eric Yarborough have taken together.
Yes. Eric Yarborough is a dear friend of mine, but also the immediate past president of the the Association of Gay and Lesbian Psychiatrists. He wrote the definitive book on transgender mental health, also from the American Psychiatric Association publishing. It came out last year. So I was delighted to collaborate with Eric in this pocket guide. Yeah, he's a wonderful collaborator and author.
Yeah, he's a wonderful person. And he's working on another book for us, which we'll talk about at another time. But I think he's going to be a prolific contributor to the field. So you and Eric put this idea together of developing the pocket guide. Who do you hope will read the book? You say will also have an international audience, or?
Very much so. When it comes to LGBTQ mental health, we have probably one of the widest range of expertise in this area. There are some people who know a lot about LGBTQ mental health, who see a lot of LGBTQ patients. And then there are quite a lot of psychiatrists, mental health professionals, both in the United States and abroad, who know very little about LGBTQ mental health. And they have very honest and very well-meaning questions, which to you and me may seem a little basic, but on the other hand, they have to be addressed. For example, you are in a gay relationship. Who's the man, who's the woman? Something that may sound not a very sophisticated question to some of us, but on the other hand, it's a very honest question. It comes from the right place, curiosity and empathy and warmth, and these kind of questions need to be addressed. So that's the idea of the pocket guides, to have a very, very wide audience. The psychiatrist who practices in Athens, Greece, or Istanbul, Turkey, or or Cairo, Egypt, or Rome, Italy, anywhere across the world.
The other thing I really like about this book, which I think it's got a beautiful intent, is just this wonderful 10-chapter structure. Very simple, very straightforward, and really relates to populations and identities. And I have it in front of me. Maybe I could run through it, but you have a chapter that's dedicated to lesbians, gay men, bisexuals, transgender people, queers, questioning people, intersex people, asexual people, pansexuals, and allied heterosexuals. And such a simple, straightforward, thoughtful structure. How did you and Eric arrive at that?
I think came out of the idea that in 2019 we need to know something about the culture surrounding these identities. So we start each chapter with a cultural context, and that cultural context is quite different in asexuals than pansexuals and lesbians than gay men. So we want to. Everybody has access to the internet these days, so it is not all that difficult for psychiatrists and other mental health professionals to learn about these different cultures. And of course, the book helps the practicing clinician orient herself or himself with this particular subculture of sexual orientation and gender minorities.
So what advice would you offer around seeing patients who maybe move between some of these cultures and how to make sense of the fluidity across the different cultures?
So that's an excellent question. What advice would we have for patients who may be finding themselves one day being on one side and the other day being on another side of this spectrum of sexuality? Celebrate the diversity of humanity. I would say this is the bottom line here. And it may be stressful at times, but at the end of the day, we're all humans, and finding yourself more on this side or on that side is, for the most part of the continuum of normal sexuality. So that's, I think, is the message of the book altogether.
Okay, that's beautiful. That's great. You know, in my own work, I've been very concerned about the special health needs and issues of people with limited resources, barriers to care, individuals who identify groups that are not in some way considered mainstream. And your book touches on these populations. Again, what advice would you have for clinicians to help our patients, the people we care for, who really have tremendous barriers to care? And they might be psychological barriers, they might be very practical resource barriers, there might simply not be resources available in the geography where they are. So just what guidance would you offer?
Yeah. Two parts to this question. One is the medications that we use in our world, and for the most part, the pharmacotherapy of different sexual orientation and gender minority populations is essentially identical to the classic pharmacotherapy guidelines that we have for the general population. Few very specific differences for some transgender and intersex patients, but for the most part, the pharmacotherapy is the same. On the other hand, the psychotherapy and the psychosocial interventions do depend very much on the availability of resources in the subcultures and the communities where the patient is at. In one word, my advice here is the internet. The internet has done a lot of damage, and we do in another book whether we're preparing, we're going to talk about technological addictions, and people become addicted to Candy Crush Saga and all kinds of things about the internet. But when it comes to issues of finding a kindred spirit, finding somebody from a similar community, being able to share experiences, create a community, the internet can be absolutely wonderful. And that is true for both patients and clinicians. This is a recommendation that both sides need to take advantage of.
Mm-hmm. Yeah, good. So let me ask you, do you think your book will be controversial? Are there any controversies that you touch upon in the book?
There is one controversy that the book does not really address very much, but we have discussed it, and that has to do with the issue of fluidity of sexuality and gender. There are some people, including myself, who feel that women in general may have more fluid sexualities, and there are other people who feel that this is yet another sexist structure to put women down, and feel that women have less of a robust sexuality than men. And both sides have very good arguments, very little data, but very good arguments on both sides. And that was a controversy that we felt was more like LGBTQ Mental Health 201. And the pocket guide is LGBTQ Mental Health 101. So we didn't really delve too much on that controversy.
Let me also comment on what an amazing partner you've been to APA, just in general as an organization, but to the publishing group in particular. You know, you've published, written or edited more than a dozen books, and nearly all are with us. You've done the Handbook of Office-Based Buprenorphine Treatment of Opioid Dependence, an initial edition in 2011, and then another second edition in 2018. The award-winning LGBT Casebook that was published in 2012 and won an award from the Society of Sex Therapy and Research Health Professionals. And that was in 2014 that you received that wonderful award. The Addiction Casebook came out in 2014, and that was based on DSM-5 and a very valuable contribution to the field. The Behavioral Addictions in 2015, which had really neat video component to it, which was, and you engaged your medical students at Rutgers in that project. What fun. Pocket Guide to Addiction Assessment and Treatment in 2016, Becoming Mindful, Integrating Mindfulness into Your Psychiatric Practice, and then Motivational Interviewing, again in 2017. First of all, you have a lot to say, and you say it beautifully, and thank you. I'd like to just spend a minute talking about motivational interviewing, because It's a wonderful tool and skill set, and the mindset behind it is so fabulous. Could you just comment a little bit about this idea of inviting the people we care for forward, as opposed to more negative or punitive or harsh approaches of the past?
Yeah. The original idea of motivational interviewing came out as a response to the more classic addiction treatment, which had confrontation as its cornerstone. Confront the denial of the patient, break down her or his defenses, slap them around, sometimes even physically, so that we can build them up from scratch. And motivational interviewing came around and said, no, this not only is not productive, but is actually quite hurtful, and most people would do worse for this kind of highly confrontational approaches. So it produced a different way, a different approach to the patient, a much more collaborative approach with the patient, and one that celebrated self-efficacy, that the patient can do it herself or himself, and expressing empathy to the patient, being in this journey together. One of the more unique parts of motivational interviewing was the idea of developing discrepancies. Other psychotherapies, including cognitive behavioral therapy, aim to resolve ambivalence, to move people forward, to help them change, to remove obstacles from in front of them. And motivational interviewing takes a step back on this one and said, no, ambivalence may be a good thing, especially in the beginning phases of treatment. We like discrepancies. We like when people get confused about where they're at and where they would like to be. It's an opening. And that's why motivational interviewing does particularly well for people who have no interest in changing anything in their lives, or have very, very little motivation for changing their behavior or treatment. Motivational interviewing identifies this tiny bit of discrepancies between where the patient is at and where the patient would like to be, drives a wedge between the two, and actually helps them move forward. It's a truly counterintuitive in a way, but quite effective approach. And from the more general to the more specific, if people who listen to this podcast, they want to gauge themselves as to whether they're really doing motivational interviewing or not, research has shown two parameters that bubble up as the ones most predictive of being faithful to motivational interviewing concepts. And they're very simple. Number one, if the patient talks more than you do, there's a very good chance that you're consistent with the motivational interviewing. If you find that you're talking more than your patient, there's a very good chance that you're not consistent with motivational interviewing. Mm-hmm. And the second one is to do more statements than questions. If you are on a ratio of 2-to-1 statements versus questions, there's also a very, very good chance that you're consistent with motivational interviewing. Reflections, whatever the patient says, either a simple reflection, just tell her or him what they just said, and you'll be amazed by how much this facilitates the conversation and lets the patient bring up all kinds of other things, or more complex reflections where you put a little bit of interpretation in your reflection. Think back about your psychodynamic psychotherapy where we do a little bit of interpretation. Either or, just state it back to the patient. Don't inflect upwards at the end of your statement, making it a question. Just go all the way down, just make it into a statement, and you will see how many wonderful things are going to come out of your patient's mouth.
That's amazing. It does make me think about how I think many clinicians would love to be able to adopt some motivational interviewing techniques in their practice, but feel a little intimidated by taking on a whole new skill set. So just that one example is how people can begin to incorporate these techniques right away. Are there other very simple, straightforward approaches maybe to start with to integrate into one's clinical practice?
Yeah. Something that we wrote about and we published it with Carla Marienfeld, who's one of our co-authors of the motivational interviewing, along with Bashar Arnaout, is the idea that it's a very simple technique. It's just do it. We titled our article, and part of it is to Another idea that could be very helpful to somebody starting a motivational interviewing work is not to be afraid to give advice to the patient. Sometimes motivational interviewing has been misinterpreted as being a very passive approach. This is not it at all. You can be very upfront with the patient. I have an agenda, of course. I would love it if you were to quit cocaine. Who wouldn't? Of course I would. That's my goal. And I'd be very upfront with you that I would like us to get to the point where you would not be using cocaine at all. But this is your life. This is what you're doing. And I'm here to help you. So don't be so much caught into the idea of what you want versus what your patient wants. You may have different agendas. This is perfectly okay. You don't have to be coy about it. You don't have to dance around it. You can be very, very upfront in a motivational interviewing sense. So that would be another major advice I would give to people starting motivational interviewing.
One of the very first techniques I learned was, asking a patient, how much do you smoke a day? And they'll say a pack, and you'll say, why not 2 packs? And it's so unsettling and so disruptive and so non-judgmental. Yeah. And it makes the person feel like they've actually achieved something.
That's a wonderful, wonderful one. What it actually does, this paradoxical intervention of just saying, okay, I'm surprised I thought you would have said, 2 6-packs and just said 1 6-pack or whatever it is. It forces the patient to articulate the little crumbs of motivation that they may have in their own words and then capitalize on that. Instead of you telling them about the promised land and how wonderful life will be if they stop using or if they cut down, you just force them to say, what is it in themselves that they have already achieved? What is the little motivation that they have already been able to put in place and then capitalize on that one? There is one thing that I would like to bring from one of the other books that you so kindly mentioned there, and that is the Buprenorphine book, the office-based buprenorphine treatment of opioid use disorder. Few people know that this is the only volume, the only book that the government has sanctioned to give you the buprenorphine waiver. What I mean by that is that by studying the book and passing a rather straightforward 20 multiple choice question exam on the internet, you can get your waiver instead of taking one of those live or internet 8-hour buprenorphine courses. So the second edition, not the first one, but the second edition of the buprenorphine book does give you the waiver. And I think this is an incredible resource for people who have very busy lives and they just want to study the book on their own time and then take the exam. It's an alternative to the course, and I just want to make sure that people know that.
Yeah, no, so tell us a little bit more about that. So you worked it out with the FDA where they saw that the book essentially represented the core curriculum necessary for this prescribing privilege?
Correct, and SAMHSA more specifically. And yes, SAMHSA gave us the okay for that. Again, the only book out there that has this privilege of being able to grant the buprenorphine waiver. John Renner was the one who did most of this work.
Well, Petros, I want to thank you so much for talking with us today and really the wonderful work that you do in our profession. I'm personally very grateful to you. And I think the world's better for the work that you do. Thank you so much.
Thank you so much, Laura. Thank you very much.
Our original music is by Willow Roberts, our executive producer, Tim Marney. This podcast is made possible by the generous support of Stanford University. We are a production of American Psychiatric Association Publishing, John McDuffie Publisher. Be sure to visit psychiatryonline.org/podcasts to join the conversation, access show notes, and discover new content, or subscribe to us on your favorite podcast platform. Thank you.